Hey, good morning. Thanks for joining us. I know 8 a.m. is an early start, but particularly if you've enjoyed our Nashville scenery. So welcome to day 2 of our first annual conference. I'm glad you're joining us this morning. And actually we really have some nice, exciting presentations for the morning. I'm going to moderate this morning, and then Dr. Amy Vanderwood will moderate for the afternoon. Before we begin our first session, I wanted to quickly, again, thank you all for coming. Thank our speakers for traveling and preparing. And then finally, thank our sponsors for helping us make this possible. If you haven't already done it, if you can download the Total Health Conferencing app, that's a real easy way of watching these later on. It's also a way that you can message us during the presentations. They're actually Q&A. When we have question and answer sessions, you can actually type the question and answers there, and then I can read them off, so that makes it nice and easy. Further plug, we have Slack at OneOncology. We're trying to use Slack to help with clinical communications. So, for instance, virtual tumor boards, being able to discuss educational sessions, being able to direct message your partners from across different practices. So there's a Slack site outside booth. They'll help you download it and get it going. But you can also message us during Slack during this for questions. I'll try to monitor that. Just trying to figure out any way we can increase communication across the platform. We have some great partners, some great practices. The more that we can communicate, I think the more we can elevate the level of our discourse. Okay. Speaking of elevation of discourse, we get to start with Tom Stricker. I actually had to apologize earlier this week to Dr. Ben Park, who heads the Vanderbilt Ingram Cancer Center, for stealing Tom away, because Tom has such great insight of the challenges we face with precision medicine, but he also has a lot of ideas for solutions in that. And so Tom's going to speak to us today on how do we bring those solutions to the clinic and help our doctors practice at the level they want to. I think we have some amazing doctors, and the more skill set, the more tools we give them, the better they can perform. So again, I'm going to turn it over to Tom Stricker, who's now Medical Director for Precision Medicine at OneOncology. He's also the Technical Director in Molecular Genomics Studies at Tennessee Oncology as well. So Tom, thanks for joining us.
Thanks, Davey. All right, thank you, Davey, for that introduction. So I'm here to talk about precision medicine. We can go to the first slide. Oh, wait, I have the advancer. Excellent. This is essentially the problem. I think there are 60 gene drug combinations up here. And I know that at least one person's going to come up to me after this meeting and say, "But you left mine out." So, and I didn't do it on purpose. I did try to do this from memory, just to see how many I could get, and that answer is probably too embarrassing for someone who's supposed to be good at precision oncology. So, I'll let that one go. The other sort of issue that we have, and as I was thinking about this talk, I wanted to move this slide up. So we're going to jump ahead, and then we'll jump back. So this is a lollipop plot, what we call, of EGFR. And so this is each of those green dots that you see, or each of those dots is a mutation spread along, and we're showing the length of the gene. So that shows the position that mutation is at. And then the sort of height of the line is how many mutations are at that position. So, we see some of our most common mutations, our favorite mutations, 858 is got a pretty big line. But then you see this lawn of like little green dots that are basically single mutations that are showing up in everyone's favorite part of the NGS report, that is the VUS section. And then, those are probably not all that interesting for the most part. But you'll see some of those that are just sort of peeking their heads up above that little green lawn. Those are also probably appearing in the VUS. And so we'll get asked, are those actionable or not? And the answer is, well, we don't know yet. But those that are a little bit more common in these patients, maybe they are actionable, particularly if they're in the kinase domain. And so we have to keep track of not only all of those drugs and gene sort of combinations, but then which mutations actually matter, because we can get lots of EGFR mutations that don't. And then if we do find out that some of these less common mutations are actionable, how do we let people know that we're going to move that out of the US into the sort of actionability column? So can I go back? Keeping track of all that data and keeping track of all of these genes and drugs and more that are coming is the sort of crux of the issue of precision medicine and what essentially we're trying to do in the precision medicine office at OneOncology. So what we want to do is help you get to the right test at the right time for the right patient so that we can find the right therapy for that patient. And so we want to provide support at the time of test ordering to make sure that we're ordering the right test. Circulating tumor DNA tests are great and have definitely have a place to work. If the tumor is not shedding, if the disease is stable, you may not find anything in that assay, and so it may not be appropriate at that time to sort of order for that patient. And so we want to make sure we're getting the right test. So once that test comes back, initially, you may have questions about what that result means, and we want to be able to provide support for you at that time as well. And I think it's whenever there's a clinical decision point that is reached, once you have done NGS, it may be, we want to provide support there as well. It may be that we can use the previous report to inform that clinical decision support. It may be that our recommendation would be to order a new test. And it sort of depends on the patient course and therapy, but I think these are living results. But they may be 2 years old, and so remembering what was in that report can really be difficult. So we want to make all of this more simple, so that you have more time to work with your patients and less time sort of wandering back through the EHR to try and find something that you did 2 years ago. So we are building a handful of support tools that are going to help practices implement precision medicine or support them as they implement precision medicine. So the first is a molecular helpline. We're setting up some molecular tumor boards. We're creating a variant identification and notification service. We want to provide testing algorithms that are approved and that match pathways. And then, this was mentioned a couple times yesterday as well, we want to create QA/QI initiatives. We don't know what we do well or what we do less well until we measure things, figure out what we're doing well, and then figure out what we can improve on, and then build interventions to improve on those things and then show that we have indeed improved on those things. So we're going to talk about most of these as we sort of work our way through today's talk. So the first is molecular helpline. The idea here is that molecular help request is initiated. We want to create multiple ways that you can ask for help, so including email, Slack, and hopefully essentially an order or in the EHR. That request will come to the precision team, which right now is myself and Neha, who's you can find around the meeting today. And we're going to use literature, real-world patient data to aggregate evidence about your particular question. And then our goal is that you'll receive a response in 1 to 2 days so that we can get that question answered in a timely manner for you. We are live at 4 sites, and there are 2 more on deck after the annual meeting. We are working with Flatiron to facilitate EHR integration for ease of use and reporting. So that has been, I think, one of the more consistent requests from our people we've talked to as we've gone live with this, that they live in the EHR. They'd rather just have the request be in the EHR And so we're going to work to try and make that happen. So, and then we are working with OneR and individual practices so that we can include personalized trial options when appropriate. And we're also exploring internal annotation engine options for the variants at scale as we build our internal database. This will help us be able to answer these more quickly with a smaller staff, essentially. So that'll enable us to go faster. Answering questions about particular variants can be time-consuming to go through the literature review, but there are databases of people who have sort of already done this. And so if we can leverage our ability to get the data in a structured format into databases, we can leverage those annotation engines and generate that data for your particular question, essentially using computers instead of people. So, all right, molecular tumor boards. So we have a weekly molecular tumor board that's hosted by OneOncology with FMI support that meets on Tuesdays at 4 Central. We have a pretty steady crew of people who show up, and I think we've had some really good discussions. And then we also have our educational tumor board, again with FMI support, that's monthly. We are working on creating additional tumor boards and trying to think about what makes sense. So, 4 Central works for a lot of people on the east and central coast, but certainly our west and mountain time folks, they're in the middle of clinic. And so trying to come up with tumor boards that fit for the different time zones is something that we're looking at too. The FMI support has been great, but we would like to get to, FMI is probably not the most popular sequencing platform among all of the practices at OneOncology. Certainly we have a lot of Keras and Tempus that is sent, so we'd like to have a vendor agnostic platform as well. And then we've been discussing a perhaps quarterly germline or hereditary cancer tumor board, just discuss issues around germline testing, germline results, interesting germline results, those sorts of things. With Slack coming on, we'd like to start or restart the asynchronous or on-demand MTBs, but moving those from one community to Slack. I think those have been were pretty useful, but I think you'll find Slack to be really a great way to interact with cases. And then, as we've gone out and talked to different practices, one sort of theme that has come up is they already have tumor boards. These are often process tumor boards that are not molecularly focused, but are sort of all-encompassing. But having some precision or molecular support at those existing tumor boards for individual practice might be useful. And so that is something that we're exploring as well. I think we have a concern about staffing if there's a lot of those, but we'd be very interested in sort of piloting that with groups if groups are interested. All right, the variant identification and notification service. So our NGS data from sequencing providers is organized into a relational database and stored in Databricks right now. So we can access that data in a number of ways, including at command line. The FMI data is fully processed and available. And hard work from Andy and Garrett is going to have data from other sequencing companies similarly organized. So in hopefully a few weeks, maybe a couple months, we're going to have all of our data. And that data then comes in on a live stream. So basically, we get feeds every day. So I can see what happened sequencing-wise the day before. So this is a little search that I did. I just wanted to find all our NTRK fusions that we had. So we went and looked for all the NTRK fusions. This enables us to do a variety of things. So I have 2 filters live right now. I run these weekly. The first is looking for somatic variants in genes for which there is either a targeted therapy or perhaps an indication of resistance. So not all KRAS is treatable right now, and G12C isn't. I don't think it's approved yet, but HRAS and KRAS are up there because they can cause resistance to like cetuximab. So I'm also pulling MSI and TMBs, and then we're looking at short variance copy number changes in fusion. So I get a table of these every week for FMI data. I'll get a table of these eventually every week for most of the sequencing that we send out. That means if we have actionable variants, we can start to build clinical decision support that will let you know that you have an actionable variant. I'm also have built a germline filter. This one is, so we've got like 66 genes up here. We're filtering on allele fraction between 40 and 60 or greater than 80. Those are indications that it may be germline. This requires a little bit more sort of manual filtering at the end. So we are throwing this through a second filter that's only looking at things that are pathogenic or likely pathogenic in ClinVar. Even after that, we still have a lot of TP53. There's not that many leaf for many out there. These are somatic mutations that are at 50%. So there's going to need to be a little bit of manual filtering. But for things like BRCA1, BRCA2, and actually PALB2, it's pretty good, actually. And so if we have a patient that has a somatic sequencing assay that has a likely germline BRCA1 or BRCA2, we can let you know, or let a genetic counselor at your practice let them know. So there's a few things I'd like to do in the future. They sort of require getting all the data, but once we get all the data, I'm excited to implement these. So the first is finding patients who have a test without a clear driver. So if you fusions are hard. RNA helps. RNA doesn't fix the problem probably entirely. And if you don't have a clear driver, it may be that we just didn't find it. And so as a pathologist, false negatives are the things that keep me awake. I think we're pretty good at false positives. We don't have that many of those anymore. These assays are pretty good. But I lose sleep at night worrying about false negatives, because if there's a patient out there that has a targetable variant that we are not finding and treating, I'm going to feel terrible about that. So we want to make sure we don't have those. And so looking through, I will say this is particularly a problem if there's only ctDNA and no tissue. Sometimes that is what you've got, and so you just have to move on. But I think knowing that, hey, you don't have a clear driver here, you should think about another test may be useful. Making sure that all our patients with advanced stage cancer have comprehensive genetic profiling. I don't suspect that this is a real big issue, but it's always good to check and make sure. Looking for patients with older tests that are covered by new FDA approval. So we do that now. As new approvals come in, we'll do a search. And then being able to set up for clinical trial matching. I do that for a couple of the TO docs already upon request. So once a week, we have a couple TO docs who get an email saying if they found anybody for their clinical trials. And eventually, what we'd like to get to is clinical decision support in the EHR that is triggered by therapeutic decision making, right? So these are things that are going to run when the test comes back. And so it's a new test. I'm going to see what happened that week and send results back. But we have a new approval for a new variant. But if you're not, so we'll let you know. But that patient may not be ready to switch therapy, and now it's a year later, and it's not on the report because the PDF is old and it's not updated. And so how do we? What we'd rather do is, you're in the EHR, you're thinking about a therapy change, and then a window pops up and says, hey, this isn't on the report, but this patient is now eligible for this therapy. So that's where we'd like to get to in the future. That is not a short-term goal, to be clear. So, all right. So we also want to give you guys data display. This is admittedly mostly for me, but if I'm going to build it, I might as well let you all see it too. So I already showed you this already. This is all the mutations in EGFR. So you can look at a gene view, and so you'd be able to see all the EGFR mutations that have been generated at OneOncology practices and get some information about them. If you wanted to go filter and look for your favorite mutation, or you want to see how many people have a certain mutation, or you want to see if your mutation that's on your list is here, you can go do that. Obviously, that's what we're here for, so we're happy to go do it for you, but I think there's probably some people in the room who would find this interesting. And then there'll be annotations associated with that. So if you hover over, oops, let's go back. So there's like a little target and a fire sign and some other things. So these are linked out to like CivicDB, which is a open source sort of community curated, it's like a Wikipedia for cancer variants. It's hosted at WashU. The fire sign is done out of MSK. It was looking at hotspots, essentially. So looking at all of their sequencing, are there recurrent mutations that are interesting? The third one in is My Cancer Genome. The first one in is OncoKB. And if you hover over this, it'll bring up, so I'm hovering over the OncoKB annotation, and it brings up the resistance to drugs, sensitivity to OC, and then on the little book sign, it'll actually take you to the references that support those. So T790M, I think everyone knows, but there may be variants that are less common that you can go look at and collect that evidence. This will also allow sort of easy display of a patient level data. So this is a single patient, their mutations, copy number, TMB, as well as then some cohort level measurements as well, so that we can sort of collect and visualize our sequencing data. All right, testing algorithms. Pathways are coming, and I know people have been talking about that for a while. I think for a lot of pathways, there'll be recommended testing because you have to know certain biomarkers so that you can fill out the pathways. Sometimes that's pretty easy. Sometimes we need CGP and PD-L1, and that's pretty straightforward. But sometimes it can be a little bit a little complex, and the pathways that are being built then will define a set of necessary biomarkers that you need in order to fill out the pathways. So what I would like to help with is design recommended testing algorithms that feed to an easy button that you press to say, I need these, I want to fill out this pathway. We're going to make sure that then those tests are ordered so that you don't have to think about making sure that you have all the tests ordered. Pathways tells you what you need to order, and so we're just going to try and make that easy for you. And eventually what we'd like to get to is have comprehensive reports and structured data so that when you're filling out pathways, we can pull all that data together into a single place so that you can efficiently fill out those forms without clicking through a million times to find all the different tests that you need in the EHR. And this is just an example. So as I said, some colorectal cancer, metastatic, you need comprehensive NGS that carries MSI and TMB. But if it's regional, depending on whether it's sufficient or insufficient, you might want MMR versus MSI, and then if it's MSI high, you should probably get BRAF, and if the BRAF is negative, you should probably get MLH1 methylation, and if that's negative, you need to send a germline. And so this sort of sequential testing is also really difficult, and we'd like to simplify this for you as well, so that that we can sort of handle this testing schema for you. You order testing for regional testing or like MSI MMR testing for regional colorectal, and the cascade follows without you having to log back in and order BRAF or log back in and order germline, et cetera. So. All right, so our QA initiatives, are the right tests being ordered for the right patients? So we want to measure both over-testing and under-testing. Are the results of the tests being used to guide therapy? So if we're finding EGFR mutations, are we prescribing TKIs or are we doing something else? And then identification of germline variants and referral to hereditary cancer to make sure that we're finding those folks, and then treating them appropriately. And we want to, I want to expand into markers beyond just comprehensive genomic profiling. That's a little tricky. So because we're getting a database of all of our sequencing data, I can make Garrett do fancy things on the computer side. If it's stuck in a PDF, it's a lot harder to do. And so PDFs are the sort of the bane of our existence as a precision medicine office. All right, so what's the future? These are things that I see coming not immediately, not in the short term, but in the longer term. So clinical decision support in the EHR at the right time. So notifications of new variant information when we get them. So variant gets upgraded from a VUS to pathogenic. We want to be able to let you know that has happened. Or there's a new FDA approval for a particular variant. We want to let you know that has happened. But we want to let you know that in the patient chart as opposed to an email that we send. Want to be able to generate comprehensive biomarker reports. So, where we pull together the genomic sequencing and we pull together perhaps the hereditary cancer panel that's been done, and we pull together PD-L1 and MMR and MSI and pull all of that together and put it in a single spot so that you can quickly get all the information you need, interpret all the data that you need to treat your patients. And finally, we'd like to leverage CGDB data at scale. We have a lot of data. Garrett sat down and sort of calculated how many NGS tests we order a year as a OneOncology, all of our practice together, and it's a tremendous amount of data. And I sit around and look at big data all the time, and we have a lot of data. It is, can we do things like, say, tell you that historically, patients in your cancer type with this driver do better or worse than average historically in our database. I think there's a whole lot of questions or information that we can provide to you about how patients who look like your patients do. And we can also provide information about what have your colleagues done with patients like this in the past. So Dr. Daniels and Dr. Aerosmith had put together a proposal to FMI and Flatiron to look at what do people do for lung cancer after their first TKI, if they have an EGFR mutation. And the answers to that, we're going to submit to ACR. I don't think I'm allowed to talk about it yet. The answers to that are actually pretty fascinating. And I think pretty informative. And I think being able to provide you that information for your patient when you get your results will be really interesting. And I'm sure there's a whole bunch of stuff I'm not thinking about. So I would love to hear from y'all about what information do you think we could get out of this database that would help you treat your patients. And that is the end of the talk. So thanks everybody for your attention.
So we actually have 5 minutes for questions. So, while we're figuring out who wants questions, a couple for you. So there's a perception in industry and elsewhere that communities, oncologists do a bad job at testing. I think that was based on data presented from another community oncology network. It's now several years old, and that data at that time was several years old. So I think it's it often reflects what was done in a prior era. What do we know right now? How easy is it to tell? I would say add that we've submitted an a manuscript rather, for how OneOncology is doing, and I have to say we're doing well.
Yep.
But give us your perspective.
So I think we're doing really well. It's certainly not for I'll be honest, it's not for a lack of ordering. I think we're ordering a lot of tests. Like it is a tremendous amount of data. So I think we're testing appropriately. I think there is perhaps a little bit too much ctDNA, just to be honest.
Is that tumor specific? Opinion?
So I think there's very specific times and places where ctDNA is super useful, and you run the risk of, if the tumor's not shedding, that you're not finding what you need, and so that is, that would be my concern about sort of over ordering ctDNA. But
and you've already pointed out that testing until a genomic driver is identified, or until at least a signature that you're measuring the genomic profile.
And I think, I'll be honest, I think the testing companies kind of do not a great job about this, because it's almost never that you'll get a stone cold negative ctDNA test. You will find chip variants or germline variants, and so you'll see mutations or variants on the report, but they probably don't have anything to do with your disease that you're looking for. And so that gets tricky because it doesn't look like a negative report, right? Because they don't say it's negative. And there's plenty of, so what they'll do is they'll say, oh, there's a low tumor ctDNA fraction, but that happens plenty of times. They put that flag on and you have a driver. So everyone just ignores that because it's not meaningful. So.
Awesome. Yeah, can we get a microphone?
The first virtual question, how near are we to building AI platforms to guide NGS decision support?
Yeah, that's a good question. I am not particularly close to building ML, but that is probably on its way. My guess is that it will not just leverage NGS results, but also scan slides. So it's going to be sort of a multimodal AI. It would be the most useful. So
until then, we have to invest in people, I guess.
Yeah.
So one thing, OneOncology, you can tell, I mean, Tom's spending half his time at TO and half his time at OneOncology. Neha Jain has joined his team. This, we think, is how at OneOncology we help our physicians in our practices. This is a cost, but it's appropriate because it changes how we take care of patients. Additional questions?
So, yeah, just a comment about the ctDNA versus tissue. I'm in San Antonio. We have an issue with getting the tissue out of the hospital, 2 to 3 weeks turnaround, whereas blood in our office is a faster turnaround. So we're a little bit more biased towards that, at least initially.
Yeah.
The second thing is tissue adequacy. You know, the small samples, the limited biopsy sample is still an issue, and sending a patient multiple times.
I was pretty sure that was the major driver of this, and I feel your pain. When at my previous institution, because the surgeons worked for us, we were able to force them to get bigger amounts of tissue, and the interventional guys worked for us. I think it's much harder, sort of in our position, to do that. And then the refusal to give up tissue is, as a pathologist, is infuriating. So I think, and that's why I do think hopefully that sort of lack of driver filter will be useful, because we'll be able to flag for you, hey, this, then you need to try and get another biopsy or something.
So for our practices, a couple of things. So we're making the vendors tell us turnaround time for our practices. So that helps us understand. Two, FMI is able to give us by hospital system what their release date is, how long it takes them to release, which I think you can then use to reach out to the hospital and say, you do the worst job in our entire 15 practice network across the entire country. Sometimes shame helps. The third thing is some practices, Tennessee Oncology has actually had to go really far and saying, we're going to avoid using your hospital for biopsy unless you release that data. I'm going to call out a group. Path Group is particularly bad at this, and I think we finally came to a solution, but it was after a lot of work. They were wanting to use their proprietary test, and actually it was a real problem, and particularly if you're being thoughtful about which tests you're wanting to order, I think it's totally inappropriate.
Yeah. Well, and there's the 14-day rule, and inpatient versus outpatient and DRGs. It's made overly complicated by some of the Medicare rules, which I'm sure is no shock to anyone in this room. So,
one last question. Smita Rao.
Yeah, hi, Tom. Thank you for your presentation. I have a question about the variants. It's kind of a two-part question, but with your variant assessments, are you looking at the blood sample to weed out the common variants that are already present in a patient? That would help enhance your variant for the somatic.
Yeah.
And the other part of my question was more tactical. If I have a variant now that has a discordant call or something, how does one of our practices reach out to you to ask for your expertise on that?
So the first question, so these are, in general, these are somatic only tests. Tempus can do match tumor normal. So Tempus will filter, and then they'll throw up a germline flag that is probably the most meaningful among all the testing companies. The other, so Caris and PGDX, which is a local, you can run internally, or TSO 500 you can run internally, or FMI does tumor only. And so you are, they're filtering with Nomad and that sort of thing. Big databases of common variants, but there's common variants are definitely coming through. Not common variants, germline variants are definitely coming through. Some of which may be meaningful, and some of which maybe not. ctDNA, especially from Foundation, you'll often find, this is where ctDNA is great, because you often find BRCA at 50%, and then some tumor mutations at 2%, and so you're pretty sure that BRCA is a germline variant, right? So it very much depends on the assay, and then sort of the tissue source. It sort of helps us filter that, but there's going to be some noise, and there's just not much you can do about that. And the second question, so we have helpline emails that are set up right now, and Slack. And so I probably should have put those on the talk about how to reach us through Slack, but we'll send that out for other folks.
Awesome. Thanks, Tom. Yeah, go by Slack. They can get you on. You can start hitting them up. And Tom, thanks for your work. I think probably one of the most exciting things on the clinical side we're doing at OneOncology.